yourself away. We are going to have Q&A at the end of this event. My name is Louise Patmore. I'm the Systems Change Lead for the Changing Futures programme, we're hosting this event today. And I'm joined by Abs Hack from West Sussex Violence Reduction with West Sussex County Council, and Joe and Bennett and Joe Walker from Brighton Changing Futures operational team and CGL. Abs, would you like to say hello to people?
Good morning, everyone. Thanks for joining the meeting today. So my name is Abs Huck. I'm the Serious Violence Lead for West Sussex County Council. It's a role that was brought in as a result of the Serious Violence Duty the government introduced in 2023. Really good to see so many of you here today.
Thank you so much. And Joe Bennett and Joe Walker, do say hello to people today.
Morning, everyone. Yeah, we're both called Joe. We both work in the Navigators team within the Changing Futures MDT in Brighton and Hove.
Hi, good morning.
Thank you very much. So yeah, are you okay looking after the people coming in, Abs? Thank you. So I'll just shut that down. So Changing Futures, just a bit of a recap. I know some people were on the call in November, and unfortunately Abs and Holly weren't able to join, so you had my company, but I'm really pleased that we've got Abs and Joe's here today. Changing Futures programme was set up in sort of 2022 thereabouts. It was a nationwide programme, 15 sites looking at multiple disadvantage, and we are sort of now on the sort of the exit doors are this way as far as Sussex is concerned, but we have achieved quite a lot in our area, working with multiple disadvantage and multiple compound need, and what we've learnt around our sort of discoveries is that we actually need to pay a lot of attention to the unacceptable behaviour policies and things like that. So that's what the webinar is about today. So we will be looking at the policies. They're very much a live issue. They very much link to staff safety, to public trust, cultural safety and trauma-informed practice. And I am the chair for the Sussex-wide trauma-informed community of practice and implementation group, where this is originated from. And we will be looking at where policies meet practice with Joe and Joe. And also looking at violence prevention and reduction area from Abs Hack today. Just bear in mind that what we're going to do is we're going to spend an hour sort of talking thereabouts, maybe 50 minutes, have a short break, and then what we really want is the panel discussion and the Q&A at the end. So I really want that curiosity and sort of leaning in. What does this mean to you? What's coming up for you in your area? We do have a number of colleagues from NHS. We've got colleagues from local authority and other sort of VCSE organisations on the call as well. So very much around having a conversation really between each other on the questions that we've got on the screen at the moment. So we want to sort of be curious about where policies help and where they hinder. We do know that some policies kind of get in the way of us being able to work in a trauma-informed way. How does trauma-informed approaches change that picture? How can we use trauma-informed approaches to change the narrative around unacceptable behaviours and some of the tensions that are happening nationally as well as locally? What does this mean for staff and the people who need our services? So the focus of attention, and thanks very much for our colleagues from CGL generating these questions here. But so the main question and the focus for the day, what would it look like to create system-wide policy and procedures that provide consistent boundaries and behaviour expectations whilst being dynamic enough to flex to each individual, and what are the barriers to this? So a bit of a mouthful. Put it in the chat box sort of a bit later on. Abs?
Sorry, Martin Powell had his hand up actually. Martin?
Okay, Martin.
Just to make you aware, Louise, there's a number of people in the Eventbrite event waiting for the seminar to start. So is there a link that I can share with them?
Yeah, hang on a minute. Just bear with me all. I'll just put it in the chat box for you, Martin. Thank you very much for flagging that up.
Thanks.
Martin works in the Changing Futures programme, our project delivery officer in Brighton Hove, an amazing asset. There's lots of people thundering in again. So the trauma-informed programme, very much owned by the system, created a vision last year. We upgraded it really, that what we're looking for is a responsive Sussex community and workforce that prevents further harm, supports recovery, addresses inequalities and improves life chances by recognising and responding alongside people who are affected by trauma and adversity. So like sort of globally within the health and social care system, this is what we're trying to sort of manifest. It's not just about a single narrative. It's not just about mental health. It's not just about adult social care, very much about community. It's about criminal justice and other sort of areas of work. And this was born through lots of conversations between our wonderful colleagues with the NHS trusts that are in Sussex, our universities, all the local authorities, and lived experience colleagues with Capital and other agencies, and our voluntary sector organisations as well. So wonderfully sort of collaborative piece of work. In this, we produced the roadmap. I'm not going to spend an awful lot of time on this, and we'll share the link for the trauma-informed framework for Sussex in the chat in a minute. But really what we're wanting to do is get the conditions right, understand experiences, develop plans and recommendations for people, implement and test change. It's about doing something differently. It's not just about reading a document and finding it interesting. It's like, what can we do to sort of change things? And lastly, to embed in policies so that it kind of sticks on the system. And that's really what we're looking at today in some ways. So I just want to come back to this, and a lot of work that I've done with patient safety with the NHS over the years. One of the correlations that we have around what we're trying to achieve can be found in some examples with the aviation sort of safety developments over now pretty much 100 years. And I wanted to draw your attention this time to some of the things that, in terms of human factors and pilot etiquette, that changed due to things that went wrong. So learning from sort of failure is a very good thing to do, but we need to be able to do that in a very sort of safe way with people who are sort of looking at these issues. So there were a couple of flights in World War II. There were quite a few crashes that were manifested by the fact that people couldn't reach or understand the controls that they were meant to apply to come into land. Notably flaps, which slow the plane down, and the gear, which obviously you need the wheels to touch down with. And it was realised after the pilots were blamed for not doing things properly, that actually with tunnel vision, when people are panicking and they're coming back from raids and so on, is that they got very confused with what they're supposed, and they couldn't see things. They got very confused with what they were looking at, and therefore the gear knob is now very much shaped like a wheel, and the flaps are also shaped like sort of flaps. So in a desperate situation, people can kind of reach those objects sort of fairly quickly. And that was a safety change that was made in World War II, and that prevented crashes. It didn't prevent all the crashes. When we started preventing those types of errors within the aviation industry, human factors became more of a problem that aviation were trying to solve. And the two examples that I've got here is Avantia flight 052, 1990. There was very much poor communication between flight and air traffic control, in which the plane orbited the airport 3 times on go-arounds, didn't declare a fuel emergency, ran out of fuel and crashed. And what was there was a hierarchy sort of in place around, following a process. When there was another thing that needed to be said, that the people that were operating the plane didn't feel able or had forgotten to kind of say. This precipitated things like checklists. So the checklist became sort of more robust. They're already in place, but they became more robust. But they also worked on the relationships and the relational factors that were happening within the aviation industry about who was giving orders, who was talking to who, and who was listening. And I think this is quite relevant in the world of unacceptable behaviours and how we work together in the system relationally. The other one, United Airlines Flight 173, often used as examples of a sort of tunnel vision of hierarchical barriers that gets in the way of things happening where the pilot became fixated on whether the landing gear was up or down. It was in fact down because it had gone down by itself, but it wasn't clear on the cockpit. The pilot failed to listen to the call outs that were regular around the fuel notices, and the crash happened because the plane ran out of fuel, not because the gear was down. So the inability for somebody to listen whilst they're under stress was the main factor for that. What that did was created a way of bringing in human factors into the aviation industry called crew resource management, and this was very much around the situational awareness, communication. We will share the slides after this, so don't worry. This will be part of your kind of learning to take away. So maintaining accurate understanding of the flight environment, which is an external factors, communication, fostering open, clear and assertive communication, and decision making, employing effective problem solving and sound judgment. This included the collaboration within the cockpit around teamwork. Pilots would introduce themselves by their first names. It's one of the reasons why you hear the pilot at the beginning of the of your flight. Whenever you go on a flight, the pilot will introduce himself so you can get used to his words, and will periodically reinforce that. Leadership and followership, clear roles and responsibilities, junior members empowered to speak up, really important, and I think this is really kind of relevant today. And workload management and assertiveness. So that's just a kind of example really from aviation, which I think can help kind of frame some of the thinking today, hopefully. We know that within our sort of services, crisis points and incidents occur not out of the blue necessarily. It's around a journey. It's around something that's sort of built up over maybe a number of interactions that people might have with health and social care services. This slide is looking at some of the things that might sort of build up some frustration, some anxiety, fear in somebody before an incident occurs. And so part of this journey around unacceptable behaviour is like, how can we do as much as we can to de-escalate and to reduce the likelihood of people developing an incident, and that's with work staff as well as our clients. One of the ways we can do this is through empathy mapping. Not going to spend an awful lot of time on that today because I really want to get to our speakers, but there are some sort of information that I will give along with these slides that will be helpful for people to think about if they are looking to understanding their own local problems with unacceptable behaviours that may be helpful. Some of the feedback from our live session, I think we had a really rich conversation last week, and this is what I also want to get to in today's session. Neil Denton, I don't think he can be here. I did reach out to him from Edinburgh, just came up with this really interesting strapline around the police are often the back line, not the front line. So when we're describing frontline services, actually people are arriving actually after a number of different interactions they might have had with health and social care or criminal justice services, where an incident might occur. Another quote that we had was behavioural management sitting within the polarity between zero tolerance and unlimited tolerance, where each extreme produces harm. So if we've got, if we just don't tolerate anything, you are going to precipitate more sort of behaviours that become unacceptable. If you have unlimited tolerance, that also creates an unsafe environment. So we're very much living in that kind of balance around there. True progress depends on leaders modelling reflective relational cultures, prioritising staff well-being and learning over blame or policy compliance. So if we are following sort of policies, or if we're moving into sort of a blame culture, we're going to inevitably precipitate less resilience in our staff. More serious incidents are sort of possible. Trauma-informed organisations align with complex adaptive systems. Behaviour cannot be managed through command and control. It requires networked sense making and feedback. So the way that we work with different colleagues with different services is really important in this arena. and establishing cross-system reflective forums for shared cases and learning, linking A&E, police and voluntary sector services alongside primary care and community safety. Really, really important to get this right across the whole of the of our footprint. We have got a strategy in Sussex that was has been flagged up as an exemplar from NHS England sort of recently, and sort of shared out around its connection with trauma-informed practice. But we do have a forum where we're thinking about this within NHS Sussex, and we're hoping to do links with violence reduction within local authorities, because I think the symbiosis between those strategies are very important. And I think they can often in themselves get siloed. So the NHS will be making decisions around preventing violence. Local authorities are making decisions around violence reduction within communities and elsewhere. Actually, if they're working together, it will be much stronger. That's kind of still ongoing. What I want to do now is very much welcome Abs Hack, violence reduction lead from West Sussex, that's going to take us through what West Sussex is up to. So Abs, over to you.
So good morning, everyone. Really good to see so many of you here. So just to explain a bit about my role, really. So I'm something called the Serious Violence Lead Officer for West Sussex County Council. The government introduced something called the Serious Violence Duty back in 2023. And what that really means is working in partnership, so bringing a real public health approach to all the different partnerships, local authorities, districts, boroughs, National Health Service, voluntary sectors, to look at effective ways of working, really, looking at how we can reduce serious violence by 50% over a 10-year period sort of thing. The government have recently launched lots of new strategies, which you probably heard in the media, around the Violence in Women and Girls strategy, the Employment Rights strategy, a youth engagement strategy. So these are all things coming out. Some of these were just launched in December of last year. But really, the key thing is there'll be more guidance coming about how that's going to support it. But the key thing is around prevention, effective working, trauma-informed practices, really, and what it really means for us as individual professionals. So for me, when we look at impact factors, there's so many of you here, we all have different roles, really. Some will be in the National Health Service, local authority, policing, voluntary sectors and businesses. But the key thing around it is we're working with sort of stakeholders, partners, people, whether you're a senior person in an organization or somebody on the front line, we all have legislation we need to follow. We have internal policies, statutory duties and things that we need to kind of do. So, but your lens will be different to your manager. Somebody who's a policy writer will say, okay, these are the policies that we must follow. This is the steps that you must do. But again, as a practitioner, there's also a different thing of how you interpret that legislation, the lens that you see it under to do your job. So the key thing is we plan our days. We focus on completing tasks. We want to make sure we hit our key performance indicators. But again, there's certain times of year when some of these things go awry. So again, winter period, for instance, demand goes up, staff go sick. We have an increase in people coming in. So if you're working, let's just say for the voluntary sector in terms of homelessness, something called SWEP's going to come in. So local authorities are trying to house people in sort of off the streets into buildings and that. So there's a drain on staffing, there's a drain on resourcing. If you work for the National Health Service, for instance, there's a drain. Accident emergency departments become really, really full. There's a lot of people there. And again, the challenges around staffing, the challenges around managing expectations of people coming in, and and then again the issues around, you have the media pieces, staff are working really, really hard to deliver what they're doing, but because of resourcing, because of budgets, because of other constraints, there's issues, isn't there, where generally your customers, your patients or whatever aren't happy that they're not getting the service that they kind of expect. And again, similar to libraries, so libraries will have an influx or an increase in people being sent there to to go and get support and that, but sometimes the partner agencies don't turn up, so that poor person working in the library then has that increased demand of trying to understand, okay, how am I supposed to deal with this person coming in? They don't always understand the trauma that person faces or the lived experience, and equally the person on the other side doesn't always understand the person who's trying to deal with this problem, the challenges that they face, I suppose. So these are the different lenses and support sort of things that we need to kind of consider. But I suppose after a while, the point is we become so focused on delivering. We know it's busy certain times of year, so we try and develop things quickly to make sure we can get our jobs done. It becomes business as usual. And sadly, with some of those things, you can get compassion fatigue in your jobs. Unconscious bias can creep in. And these are some of the sort of things that factors that we need to consider around the trauma base, really. Can I have the next slide, please? Thank you. So the consequence of those pressures and that things that happen. So we generally know that during the winter periods, or we know when our busy periods of time will be, but there's a huge risk that we could fall down. We could have a massive overload in terms of how am I going to cope with this? Do I have the capability and capacity to deal with all of this? So the reality is we could all fall down with this, with the demand that we're facing, with the needs that are there. Does our organization or our managers understand what we're facing and how we're trying to deal with it? Do I understand the needs of that stakeholder or person coming in as well? So those are the things. So there is at peak times we could all fall down. Can I have the next slide, please? So again, it's just understanding again, it's okay to feel overwhelmed. At some points, we're going to find the stresses. We're going to kind of consider that. Do our employees know how we're feeling? Are we feeling supported? And again, with some of those stresses that come from all this type of approach, I just want to give some statistics and facts, really. So again, in terms of a violence reduction sort of perspective, if we're talking from a National Health Service perspective, 1 in 4 of NHS staff are from ethnic minority backgrounds. So they're more likely to face sort of hate crime or hate incidents. 77% of women work in the National Health Service. So again, quite often they're subjected to, violence, sexualized behavior, verbal abuse and threats, bullying and harassment. So these are sort of big impact things and things that need to be considered. But we can all feel overwhelmed by certain times of year when that demand is high, there's not enough staff there, there's not enough support. But again, in terms of mitigating that, we all know these peak times will happen. We all know that there's going to be all these sort of considerations. But again, do we really consider, people's feelings, the impact those sort of behaviours have on it, And equally, I suppose, understanding sort of non-verbal communications. So when somebody's displaying behavior, they've got clenched fists, for instance, they're angry, they're animated. Are we reading the signs of that trauma? Are we really understanding that? And equally, are we then able to understand our own health and safety and risk assessments around some of those issues? So again, it's just thinking about some of those things and how we can stay safe. Can I have the next slide, please? So again, I suppose the key thing is, despite all of this chaos and busyness at certain times during our sort of working lives, that trauma-informed practice, what we're saying is about understanding past trauma and how it might affect their behavior, emotions, needs, and so people feel safe, respected, and supported. And some of this can also help prevent those frequent flyers coming back in. So I'm just going to touch on a couple of examples, really. So again, from a policing perspective, for instance, a police officer might go to see a survivor of a domestic abuse situation, and they get called to this address regularly. Compassion fatigue can set in, and sometimes the police might not be as considerate as perhaps other times. We could be in the accident and emergency department, a member of staff who's working really hard. You've got a lack of resourcing in there. You've got a lot of people in to be seen. And then you get the police turn up with somebody who's perhaps been involved in a fight, who's intoxicated, who's angry, who's upset. They come in, and sometimes other patients will feel, oh my God, this is not a very nice situation to be in or to see, sort of thing. And then sometimes the perception might be that this person is being treated far quicker than somebody who's been waiting in A&E for many, many hours, sort of thing. So it's just trying to understand how some of those traumas and those needs, again, prioritizing those needs to make sure that other agencies can do their jobs, I suppose. So it's just understanding some of those and unpacking some of those issues to get our jobs done. And again, we're all task focused. We're all there because we want to do a good job. We want to deliver something that's really key and beneficial to help support that person. But I suppose just going back to the trauma side of it, if you work in A&E, for instance, and some of the people that I've spoken to have been subjected to hate crime or, violent abuse or whatever from others, what they come sometimes feel is that, well, actually, I'm there to support that person. I'm there to care for that person. I'm there to treat them. But the point is really what you need to consider is your well-being as well, because if you get assaulted or you get injured, you're not going to be there to help and care for all the other 10, 20 other people that come forward. So again, it's just understanding your trauma, trying to understand the trauma of that person who's come in, and again, trying to look at how do our policies and procedures reflect on that. Sometimes policies are written so that we can make sure we can hit the statutory duty for that organisation, really. But again, does it really take into consideration how, maybe, women staff are feeling, people from global majority communities are feeling in terms of their health and well-being, in terms of their trauma that they might face? And again, are there been listening circles and things considered to do the debriefs afterwards, or is it because we're all too busy, we're not kind of doing that? So again, it's an understanding there, but making sure we can follow this process in a way that we all feel safe, we feel respected and supported, as well as understanding the needs of our stakeholder or customer that's come in. Can we have the next slide, please? So again, in a lot of the sort of things I've discussed, really, there's that principle of fairness. So when we're talking about the police bringing in somebody who's been violent, aggressive or whatever, and you've been in that A&E waiting room for hours on end, you're going to feel, well, hang on a minute, this isn't fair. I've waited here patiently. I've not been verbally abusive. Why is this person coming in beforehand? And then I talk about risk assessments, really. So every organisation have a health and safety, they have to comply with Health and Safety Act, basically. So we need to have risk assessments in place. Are we considering our own risk assessments? Are we doing dynamic risk assessments in those situations? Do we have the skills to understand conflict management, or do we need support around what is conflict management, really, what a dynamic risk assessment involves? And again, just going back to the bit about prioritising clients, again, it's not just those who shout the loudest. I know quite often we will prioritise the care need of that person, perhaps, or the support need of that person, depending on whatever role that you're in or whatever that business need is. But sometimes it's easier to buck the trend and think, you know what, although there's a policy and procedure in place, this person's been a right pain in the what. So we're going to see to them first, get rid of them, and then we're going to deal with everybody else. But again, it just bucks the trend of, is it fair? Not really. Does it help the risk assessment of everybody else in that environment? So if one person has come in and you've got a waiting room full of 50 other people waiting to be seen, could be children, could be elderly people, could be vulnerable people, exposure to that violent confrontation of that person is perhaps, under the influence of alcohol or drugs. Is it in the best interest of everybody else? So we're kind of looking after their trauma to make sure they're not traumatized anymore by dealing with that person first, really. So again, it's just having those wider considerations around some of these things. Next slide, please. So again, what does it mean? Again, some of it is around self-reflection, really, asking questions appropriately. So, can it be we can reframe some of the questions we're going to ask somebody? So again, I've put some examples down there, like what's wrong with you to what happened to you. Trauma comes from many, many different experiences, really. Some people have perhaps a lack of trust in the police, lack of trust in local authority, lack of trust in doctors and nurses. Some diverse communities will feel that if they tell somebody in authority about something that's happened to their child or situation, that their child might be taken into care or custody, sort of thing. Some people also feel that if they're from sort of deprived backgrounds, that they might not be treated, fairly. They might not get the same level of service as perhaps somebody who's more affluent or better spoken, sort of thing. So I suppose the goal here is we want to avoid re-traumatizing people, make people feel safe and empowered if they're there for a service or reason. Again, it's just try and provide them with the best level of service, really. And again, there's so many barriers to accessing services. Trying to understand that if we can have a trauma-informed, approach to some of these issues, we can probably unlock some of the barriers that people have or preconceived ideas about how they might be perceived when they come to get some help and support. And again, policy change. So supporting policy change is key, but sometimes what I find is when I speak to people on the front line that perhaps they feel that the policy and that legislation side of it is more for managers and senior leaders, but sometimes those managers and senior leaders are absent from the front line. They don't know how that policy or procedure is actually working in principle. Is it working, proportionately and fairly for their staff, or is it a policy that's been written that actually is a really badly but a bad policy that actually, yes, it hits the statutory duty, but actually in terms of our staff's well-being, in terms of our stakeholder engagement, it's not very good. But is it the staff don't feel empowered enough to say, well, actually, changes need to be made here to make this better for the working environment, for the workers? Because again, that will have an impact on sickness, morale, motivation, how people feel in their workplace. And again, some of those will then revolve to our stakeholders, our clients, our people that we engage with. If they see that difference in us, then they're going to engage better. And again, when we talk about the government's drive of prevention, we're talking the government's drive of understanding. If we have a better engagement process by understanding trauma, we can probably give that person a better journey and a better pathway. Hopefully that will reduce their need to keep coming back into services, which will eventually have a cost saving purpose further down the line. But again, all takes time, but we are all drivers of that change, really. We all have a voice, we all have an option to say something, but sometimes because we're so busy in the heat of everything during those peak times, we never get to do the things that really matter to us, that have an impact on us, because we think, do you know what, it's done, I'm moving on. But again, I think we need to remember that, because every year we're going to have winter, every year we're going to have peak times and certain things happen, every year we're going to have a peak time when there's going to be need for service around domestic abuse, need for services around homelessness, need for services in the doctor's surgery, need for services at the A&E department. So again, it's just thinking what we can do to help ourselves and help our sort of clients in that. Next slide, please. So again, key principles are I think we've covered most of those points. So safety, people, me working in an organization, I want to make sure I can feel safe doing my job. And again, I'm sure those coming in to see us in our services will want to make sure that they feel physically safe and emotionally safe as well. So if you're in that A&E room, for instance, and you've got that person who's come in with the police who's intoxicated, being violent and aggressive, we don't want to see that. We don't want our children to see that. And again, trust. Be honest. Again, sometimes we need to manage people's expectations, and it is hard, isn't it? So you could have a big waiting list of people coming in, and we're giving people inconsistent messages. Are we being reliable? I know some of those things will get taken out of your hands depending on the priority case coming in, but people just want to have the effective communications. Choice. Give people choice and controls. I think sometimes telling people that yes, this process will take this much time, it might not sound great, but again, with the resourcing we've got, the funding streams that we've got, and actually the work that we've got, it might be something that is out of our hands. Collaboration, again, for me is key, really. So again, when we talk about trauma-informed practice, so if you've got, you work in an A&E department or hospital somewhere where you've got more women or people from global majority communities, are others aware of the impact it could have on you? Do they know actually how you're feeling? Some of the people from global majority communities or women won't want to complain because about a behavior or something that's happened to them, because they don't want to make a fuss. But equally, if we've got good working relationships, good collaboration, we can prevent some of that. Someone can interject or come in, or if they see that you're actually starting to fall down, they can come and provide that little bit of support that you might need at that time, or just if you can go on a break. But again, the collaboration bit is key. If people don't know that you might be suffering or you're having an issue, then they can't support you really. And again, empowerment, we need to focus on our strengths, building confidence. If we've got a strong team of people working together, we're collaborative, we're open and honest, we can trust one another, it's gonna make our coming to work, doing our roles and responsibilities more better, really. And again, cultural awareness. We don't all know everything, and that's the bottom line, really. But again, it's just knowing where you can get that help and support around cultural awareness. Some communities won't want to talk about certain issues. There's a lot of stigma around it. But again, you might not spot the signs because you don't live that person's experience. But again, knowing where you can get the help and support around that really is key. And again, if we don't have those processes in place, or if it's not considered in the policy, perhaps your organisation needs to explore some of those things around cultural awareness, cultural competence, and things like that, really. Next slide, please. So why it matters, really. So again, whether you're working in the school, healthcare, social work, policing, trauma-informed practice really helps us with our empathy and care. Quite often, when you talk to people, because we're busy, because the demand is high, we might not always come across as being empathetic or understanding the needs of that person, because to that person, it could be the first time they've come into interaction with somebody from one of our sort of roles. So it could be someone raising something with the school, raising something with the healthcare, social worker, or policing. But because we do it day in, day out, we do suffer from compassion fatigue. It's just having that little switch in the back of your head. So actually, yes, this might be my 5th case that I'm dealing with of the same sort of thing, but to that person, that could be their first experience. So the empathy and the care, perhaps the cultural understanding, could make a difference, really. It'll improve outcomes, definitely builds trust, supports healings for those who perhaps don't trust our organisations. And again, individually, we're the key drivers to those changes. Understanding that trauma, giving that empathetic care and approach will make a difference. But again, in terms of our own organisations, feeding that back through our line of management, getting involved in policies, looking at things that work for us, what works well and what doesn't work well, really. So again, feeding those things back in. Right, next slide.
Yeah, thank you very much. So that was really interesting and insightful. We're going to move over to Joe and Joe, who are going to give a perspective from CGL and Changing Futures sort of arena. So thank you very much, Abs, and we're going to have those Q&As to just have those thoughts that are coming into your mind. Drop them down. Joe squared, over to you.
Am I doing it? Yeah. So we thought we're going to do a bit of sort of speak a bit about what it means in practice. Obviously, as navigators and working within Changing Futures, we work directly with a caseload of people, multiple compound needs. So it's really quite frequently that we are working directly with people with challenging behaviour. So often our clients have a history of rough sleeping, and our goal is to sustain people to access accommodation and then sustain it. The compound needs we work with are homelessness, mental health, substance use, offending, and domestic violence. So yeah, we're going to talk a little bit about what it means to work directly with challenging behaviour, and also how that informs and can suggest policy changes, for example. Okay, the next slide, please, Lewis. So yeah, just to give a bit of context, so it's certainly been shown that there's an increasing number of people with MCN, multiple compound needs, and that they require access to sort of more community spaces, but at the same time have less access to other lines of support. This is particularly noticeable post-pandemic, sort of the increase in challenging behaviour. What we certainly find and experience that increasingly we're having to make decisions in really challenging situations. So I know that Abs was talking about sort of dynamic risk assessment. That's something that find ourselves having to do frequently. It might be in public, it might be within another service. And what we want to talk to a bit is how sort of that decision making can be really impacted by sort of inconsistent policies and enforcement between services. So, if our clients are going somewhere and getting told one thing and getting challenged, in this way, but then going somewhere else and having a different experience, that can make it really difficult for us to work with them directly and try and have some consistency to enforce boundaries, which is a big part of our work. And you can see why this might be. So if we talk about thresholds for challenging behaviour, so a service like ours, which works with multiple compound needs, our threshold is naturally likely going to be increased compared to, say, the library. So if one of our clients presents at the library and is presented with challenging behaviour, you can see why the library might respond in a different way to the way we work with people. Yeah, could we get the next slide, please, Louise?
So yeah, we just wanted to highlight maybe 2 areas where policy meets practice and some sort of suggestions from our frontline experience of how sort of policies and procedures can be improved. And we're certainly not coming here with all the answers, and hope that these sort of points illuminate some discussions rather than provide sort of concrete answers. But the first of those is about reactive versus restorative responses. So if we look first at reactive, the way we would define that is responses that they might provide an immediate response against a challenging behaviour, but don't address the underlying causes or support needs affecting that behaviour. So you'd think of things like people being banned from certain buildings, people being discharged from services due to certain behaviours. And these responses, they do provide an immediate respite, especially for staff who are dealing with challenging situations. They can provide an immediate respite from that presentation and behaviour. But they can also probably be seen as like kicking the can down the road or moving things to somewhere else, whilst the sort of underlying issues remain unaddressed. Sort of in contrast to that would be restorative responses. So these would still hold individuals accountable for their behaviour, but also seek to understand and address some of the underlying support needs that might be present for that individual, and try and hold space for meaningful or reflective conversations, supporting that person towards behaviour change, through sort of trying to help that person understand the impacts of their behaviour, both on others, but also on themselves in their own situation. And we're just going to give a bit of a sort of real life example. If we could have the next slide, Louise.
Thank you. Yeah, so this is an example of someone I work with. So a person well known to services, and they went to the local authority, to the customer service centre, to make a homeless application. They were rough sleeping at the time. So this particular incident took place before I was working with them. But what happened, and what is a kind of MO for the client, is that ultimately they became heightened during that meeting and aggressive, to the extent where it had to be stopped. And closer to what actually happened was this reactive response. So police were called, and the client had to be removed from the premises. What resulted was a ban from being able to attend the customer service centre for 6 months, and there was no sort of perceivable option for that to be changed. That was sort of a blanket ban that was enacted. Other services that may have been working with the client weren't made aware, so it was purely communicated to the client. And I think certainly the biggest thing from my perspective was the fact that support needs, so homelessness, remained unmet. So they continued to rough sleep, and they weren't able to get that support from a housing officer via the council, but because they had been banned. And I suppose the implication, what it means is at the end of that ban, so come 6 months, what has meaningfully changed for that client? That means that should they get another appointment, there's going to be a different outcome. So our argument would be, through this reactive approach, there's much less a chance that things are actually going to change for that person. So what we then tried to do was sort of work together with the council with a more restorative approach. So it was boundary, but had a conversational approach to try and de-escalate the behaviour. So the plan was I'd attend another appointment, but with my client, to kind of support them to be able to manage it through sort of a relational and conversational approach. That took into account that if it was not possible, if behaviour escalated again, then we would call the police if necessary. We had prior conversations with other services, with the council, with housing, and had a talk about what sort of triggers are, what sort of language you might use, how we can give this client the best opportunity to make a success of the meeting and get their need met. So we spoke more about restorative conversation, trying to figure out where it is the client's coming from, what their needs are, and how we can best sort of navigate that meeting. And then there was talk about if that didn't work, if the behaviour did continue to escalate, then what would happen next? And I think we're going to talk a bit about that on the next slide, if that's okay.
Yeah, so this slide sort of reflects on situations where we might have either one incident or perhaps a series of incidents with an individual, to the point where it sort of becomes necessary to escalate what our response would be, either as a service or as a system, through a more like formal sort of notification process, notifying that individual of the consequences of their behaviour or the consequences of that incident. Still within this, I think the language that we use can be really important in how that's received by the person and actually how effective it is. So this is sort of an ongoing piece of work for us as a service, but just to give like a bit of a flavour of it, I'd say a lot of current sort of responses would fit into this reactive category. So you can see in the orange box, it would say something like, during your homeless application on the 11th of April, you were verbally heightened and abusive towards staff and made threats of violence. We have a zero tolerance policy towards this behaviour, and we're now writing to give formal notification that you are banned from attending the service for a minimum of 6 months. Some of these forms of communication can include some way in which that individual might challenge the decision. But like you see there, it might be like an email address that they can reach out to. If you're working with someone who's highly socially excluded, perhaps is not able to access other community spaces like the library, struggles with digital exclusion, realistically, it's very challenging for that decision to be reviewed, and their sort of support needs are likely to remain unmet. Sort of in contrast to that, what we're looking at is a more sort of restorative way of communicating some of these issues to clients. So it would say, I'm writing regarding our appointment on the 11th of April, where we'd intended to support you with completing a homeless application. We understand that your current housing situation is distressing, and we share your desire to reach a positive outcome. However, during our appointment, I felt unsafe due to the language and threats that you were making, to the extent that we had to end our appointment and ask you to leave the service. I'm still here to support you and share your goal to see a resolution to your current housing situation. However, to achieve this, we need to be able to meet and have conversations in a way that are respectful and productive. So hopefully that just gives an idea of the ways in which we're trying to shift language a little bit to perhaps take into account the sort of wider context that might be going on for that person. If we could have the next slide, Louise. The second point is around developing policy and procedure around challenging behaviour that is consistent and dynamic. So one of the things as we were preparing for this that we discussed was, as Joe touched on in the earlier slides, having consistent policy and procedure is really important. Because inconsistent approaches can be confusing for clients. It can be difficult for professionals involved to sort of set consistent boundaries with that individual in terms of their trauma-informed practice. On the other hand, policies and procedures can at times be sort of overly rigid and inflexible and lead to these quite reactive responses, because this behavior triggers this response, and that's sort of just all there is, and that can feel quite disconnected from our day-to-day sort of work as practitioners. And so what we wanted to sort of reflect upon here was how we develop policies and procedures that are enabling and helpful for frontline practitioners who are working with service users day to day, rather than being something that maybe you read during your induction and is on a shared file somewhere, but really isn't impacting your sort of day-to-day practice or supporting you as a frontline practitioner all that much. Louise, if we could have the next slide, is another sort of, I guess, real life example, obviously anonymized.
Yeah, I see there's a few questions in the chat. Maybe at the end we'll try and have a look and adjust some of them. But just to this point, so again, this is an example regarding two of my clients we've anonymised, and hopefully you're getting a sense of my caseload at this point. So there are two different people, but who've both used discriminatory language during appointments with various staff. So Ahmed is the first and has used homophobic language during appointments with his key worker. The comments are not directed at the key worker, but it certainly feels that his language can be connected to different beliefs and very possibly linked to a difference in cultural background and upbringing. So on the other hand, there's Mick, and Mick has used sort of racist and homophobic language on site at his supported accommodation. A slight difference that staff have observed that Mick's language seems to be used more to provoke a reaction from staff. And if we get the next slide, then we'll talk a bit more about it. So yeah, in terms of dynamic and consistent, so want to be consistent point from a sort of policy perspective would be that the use of discriminatory language is unacceptable within the service. So that's the consistency and the boundary. At the same time, to be able to be dynamic will allow hopefully frontline staff to be able to use the expertise and understand and construct the best way to respond, considering the person. So there's a similarity, there's also these differences, right? So in Ahmed's case, due to the background, it may not be possible or appropriate to, be trying to work to change the beliefs. Instead, an example we might be saying is, so Ahmed, I understand that we have different beliefs about this. However, that language you use makes us feel uncomfortable, and so I'm going to ask that you be respectful and not use it during our appointments. Sort of conversely with Mick, so in Mick's case, it's important to make clear that his use of language has also been unacceptable, and to reinforce healthy boundaries around engagement and support. I might say something like, Mick, I want to make clear it's not appropriate for you to make these comments. I understand that you want to meet with me to fill out your PIP form. However, using discriminatory language is going to make this more difficult. And I certainly feel like I want to sort of bring it back to something practical. Like, actually, when you use this language, it has a real world effect. Like, I'm here to support you. We've got some things we want to get done that we want to be able to help you to move forward. But when you use this language, sort of the impact it has on people is going to make all this really difficult. And so we have a boundary. But yeah, we're more keen to explore what's going on for Mick and why they feel like sort of trying to get a reaction is what is what's important to them in that moment. Yeah, we get the next slide, Louise.
So yeah, just wanted to sort of round out our contribution to this morning with like a few sort of thoughts. One of the key difficulties, I think, from a frontline services perspective is this balance between promoting staff safety and well-being, which is really impacted by the kinds of incidents that we can deal with on a day-to-day basis, whether that's sort of verbal abuse or threats of violence, experiences of sort of physical intimidation, has a real impact on us as sort of practitioners in our day-to-day work. On the other hand, I noticed the contrast between individuals we might work with who respond to trauma in a way that is a flight response, where we get really concerned about that person. We go to quite additional sort of efforts at times to try and find them, to try and engage them in support. Whereas if someone's response is a fight response, they're often sort of punished and excluded from services in a different way. Again, not something I have the answers to, but a difficult sort of balance to strike. We're often working with people who have a wide range of support needs. And that means that restorative practice that we spoke about is not necessarily prioritized. We might think, oh, I'll try and meet them on a day where they're sort of in a better frame of mind to do that appointment. And then the sort of underlying sort of issues that might be contributing to the challenging or unacceptable behaviour remain unaddressed because we're not always prioritising those sort of restorative conversations. And then the final question, I guess, is, like we spoke about, developing policies and procedures that are consistent and provide that sort of consistent expectation on individuals, whilst also provide that level of flex to respond in the best way for each person. How do you do that across a system? So different parts of the public sector have those sort of same sets of policies and procedures, and maybe what are the barriers to achieving this? Back to you, Louise.
Thank you very much, Joe Walker, Joe Bennett, and Abs. People want to give a reaction, applause for that, for those two conversations. We do know this is sitting within a tension in the system about how do we balance two sort of sides of the spectrum. We will be coming to questions towards the end of the session in a few minutes. If you can just hold on a minute, Hannah, I'd be most grateful. So I'm just going to round off with some of the things. So there are a number of things that are underway to try and sort of reach this balance, and so that we are piloting tools within the Changing Futures programme within Brighton Hove Council. We have got a conversation tomorrow around antisocial behaviour within our communities that's ongoing. Will be part of an extension to work ongoing, sort of amending products and piloting them in social care teams just to see what's working, what doesn't. We have been working with our local ambulance service as well, who've done similar things in terms of addressing sort of problems that people experience in a bit more of a compassionate way. This isn't sort of justifying actions. There's a comment in the chat box that's a very viable comment. Hopefully we can sort of draw some of that out. It's very, very difficult in terms of how we need to be providing care for our entire community, and some people have very oppositional views, and collaborating and being able to keep everybody safe is a very, very difficult topic, and it's one that I think the conversation is generally shied away from, and it's siloed. So I want to be clear around the conversation we're having in here is there are different viewpoints that need to kind of intersect in a safe and trustful manner as well. We are doing, there's quite a lot of work underway in Sussex around this, and I think the two sides of that illuminated very well between there. Of course, there are policies around unacceptable behaviours. There's also other adjoining policies to be aware of: risk management, lone worker, security management, health and safety, risk management. You can read the list there. Some of the ways of combating that is around trauma-informed skills, trauma-informed safer spaces training, which is around de-escalation, it's understanding behaviours, conflict resolution, and restorative practice. And some of these are kind of nice to do's rather than actually really embedded in commissioning and expectations around how we want services to work, not just with our A&E colleagues or anybody else, but care homes. We've got other kind of spaces, where this really needs to be thought of. De-escalation by design, to kind of try and wrap up this conversation, is there are ways of designing out some of the problems that might arise further downstream. So if we can have a sense of clarity, predictability, clear signage, so people don't get lost and they kind of know where they're going, they know where they are, they know what they're there to do, can really help de-escalate situations, and it enables us to manage more difficult to resolve problems in a better way. Consistent routines and handovers. Quite often there is confusion or perceived threat on handovers. So the way that we write about colleagues and the way that we think about our colleagues, the way that we think and write about clients is really, really important. And there's a whole sort of plethora of information around language and how that sort of enables misunderstanding. Cultural awareness, Abs and Joe and Joe talking about that very clearly. There's often unjust applications of power. Often that makes things worse, doesn't really improve things. It might feel like it improves things in the immediate, but actually it doesn't resolve the problems. So we're looking to reduce the revolving door issue that we might have. Some of Ab's commentary earlier on, something about people being in A&E that shouldn't really be in A&E, but we haven't quite built something for them on the outside of A&E that will be more supportive for people who do have multiple compound need. Looking after our workforce, very, very important. Co-production, collaboration can't be emphasised enough, and resisting unconscious bias and dehumanisation through groupthink. It's very easy for us to start using colloquialisms and acronyms and so on to describe people that dehumanises. So keeping the person in the room very, very clear. If that's a colleague that's working in adult social care and you're an A&E, you know, and vice versa, is resisting that temptation to say, oh, it's them over there. Them over there are all people. They're all individuals with needs and aspirations. Psychologically safe, connected teams, and the ability to speak against sort of bad practice, really, really key, and also promote really good practice as well. I really like this quote from Dorian Gray from Oscar Wilde, but I'm not sure this quote is actually attributed to that. This is where I got it from. It just to kind of summarize in some ways is I used to think communication was the key until I realized comprehension is. You can communicate all you want with someone, but if they don't understand you, it's silent chaos. And I think quite often in our system and clients approaching that system, workers within the system and teams are probably operating in some sort of silent chaos, and it's around the communication. And on from a conversation we had this morning around the pandemic, that was also mentioned, is that actually we've got to recognise that the trauma experience of people has got worse post-pandemic. This image came from the March, when the pandemic started. This was a graphic that was shared by NHS England with the gold, silver, bronze command that we were in back in the day, but it actually showed that the fourth wave of the pandemic was going to be trauma, and it was going to be psychic trauma, mental illness, economic injury, and burnout. And I would argue that we're looking at all of those things happening without the conversation about where that's come from. So I just wanted to highlight that, and it's exactly the same as World War II. Stop talking about that kind of national disaster that we had, an international disaster, and there's lots of hidden trauma happening in homes, care homes, and staff and patients, and it's also held with homeless community, because in the pandemic they were looked after in the right way, and when the pandemic stopped, they were then released back out into the sort of less availability of help. So I suggest that we just have a few minutes just to breathe. Thank you to the speakers again. If you want to, go to loo, have a cup of tea, just go and sort yourselves out in a couple of minutes. We'll come back at sort of around 5-6 minutes past. I know that's going to be fairly quick. And we will be looking at the questions in the chat box that I've picked out a couple, and at the panel discussion and Q&A for the remaining moments of this webinar. We'll have in a couple of minutes. So see you in 2 minutes.
Do we have any coffee? Sorry, I know you're busy.
Was that a question for me, Sue?
Oh my God.
Possibly not, I'm thinking. Okay, so fairly sort of rapid turnaround, but sort of just join when you're able to. At this point, it'd be really good to see people's the video on again if that's possible. People feel comfortable doing that. So the questions that we have are on the screen at the moment. So now opening the floor, and thanks for people's patience who were asking questions before, but I will try and prioritise those. But do put your hand up. The raised hand is up on the icons at the top of the screen. Those who don't know where they are. So questions to the floor are welcomed. Frankie.
Yeah, I actually just wrote it in the chat, but I'll just kind of read out or say what I was going to ask is, I guess, so we're a charity, so we're like third sector. We support people, and like the vulnerabilities and compound intersectionalities of those people is obviously so varied. I previously worked at Oasis Project, which is partnership with CGL in Brighton. And like the difference in the service users' presentations and like what we're experiencing is like quite different and also quite similar in other ways. And I guess it's just when we use that library and changing futures examples of like your tolerance, I couldn't think of the better word for it. You probably have one of what behaviors are considered unacceptable and that we would put like hard boundaries in for is different. Do we does anyone have any advice, I guess, on like risk assessments or just assessments in general on how you would like look at the people that you are working with and the work that you are doing and like how you would assess what your tolerance level should be? Because basically as roundabout story of it is I feel like I've come from a service where the tolerance was quite not quite high, so we were quite used to experiencing like verbal abuse and things would escalate really quickly, but then there would be that resolving conversation afterwards. It'd be like, I understood where this come from and da 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 da. Whereas I guess here I'm still trying to figure out what our tolerance levels are towards things like that. And I appreciate I'm probably using all the wrong words to try and describe that. But yeah, just wondered if anyone had any advice on that.
Absolutely fine. Abs.
Yeah, I was going to say, it's a really good question, Frankie, actually. And again, I think some of it will go down to your client group, if that makes sense. So when we talk about tolerance, I suppose the key thing is tolerances will be different. So the organisation will have a policy around health and safety and well-being sort of thing. But then what you'll find is your tolerance might be different to your colleague's tolerance, if that makes sense. You might have a greater knowledge of that client that you're dealing with. So you think, well, yeah, they're getting really shouty, sweary, all the rest of it, that you actually know that person's not going to escalate anymore, if that makes sense. You can manage that situation, whereas another colleague who might not have that knowledge of that individual might not be able to de-escalate it as quickly. So again, I think it'll be down to an individual dynamic risk assessment of that, unless you've got a known range of different clients that you have, and then someone's written a risk assessment around it that all staff have to familiarize themselves with. Does that make sense?
Yeah, that's kind of like what the process is at the moment anyway. I was just wondering if like how much of that needs to be added to, so I'm in the process of writing our like unacceptable behavior policy at the moment. And then I'm like so aware of like the background of what I'm used to when it comes to like those unacceptable behaviors. But realistically, the process is always the same. Like an incident would occur and then there's a way of either de-escalating or removing yourselves from the situation, and then there would always be that follow-up. It's not just you have that reactive response what we were talking about before, which I think can happen quite easily in services and stuff like that. So yeah, I like that idea that it's more that the process is the same, but the actual outcome isn't always the same. It's about the individual.
Yeah, so I think you're definitely on the right framework. And again, if you just put that vision, that lens, let's just say you're in a different organization, their tolerance levels will probably be far lower than your client groups, if that makes sense. So I think, yeah, I would perhaps stick to what you're doing at the moment.
Yeah, thanks so much, Joe.
Yeah, I think it may be different for sort of colleagues that work in maybe more like acute settings or sort of crisis response settings, but certainly like those of us who work in sort of community services, I think, Frankie, your question probably gets to like the heart of the issue, and I think it's what that consistent and dynamic thing is trying to highlight, in that the way things I think work a lot at the moment is the policy might say XYZ behavior is unacceptable. And then the way we work day to day doesn't always reflect that, because perhaps my tolerance levels of thresholds are higher than what the policy would be, for example. Now, like how you create sort of policies and procedures that allow for, like, individual workers have different styles of work. There still needs to be boundaries, but it's quite like a difficult like issue to resolve. I think the key thing is, for me, around one of the things in sort of trauma-informed practice is the importance of secure attachment, and the way that a relationship based on secure attachment can help to sort of, I guess, reconfigure the way that a person perhaps relates to themselves, to other people, to other services. And the way that we respond, I think, needs to be based on secure attachment. So that's not fawning to someone because they're like sort of responding in a certain way. It's not necessarily responding really combative. It's responding in a way that's sort of like true to yourself. How you can put that into like a policy and procedure that works across a whole organization is really difficult, and I think is one of like the probably key like issues that I'd like to get sort of people's views on from the call.
And then you also get that issue of like, we want to go to the policy and feel secure in our decision making, but oftentimes you can't make a secure decision without knowing about the incident. So it's like, how do you write a policy that makes you feel like you're doing the right thing, but it's also not exactly telling you what to do? And I think that can really mess with staff's confidence levels if they're reading a policy and then they're like, oh, I don't really know if that's helping me or if I still feel like I'm doing the right thing.
I was just going to add, like, I think that's really hard, right? I know, you know, Philip's also asking about sort of thresholds within a service like a day centre or something like that. Yeah, and I don't know, a couple of things come to my mind, like physical safety. So certainly, if I'm feeling physically unsafe, I'd be looking to probably end interaction around. In terms of language, it's like, you know, I think of some of my clients, it would almost feel impossible to be able to have any progress in a conversation if they weren't allowed to swear, right? If they weren't allowed to, you know, say certain things. So, you know, that's maybe something to take into account. Also, I think in regards to Philip's question, like the impact on other service users, like if someone else's ability to engage meaningfully with services is impacted by someone else's behaviour. That feels like really hard, I think, is the bottom line.
Thank you. Some of the last bits of that was distorted. Thank you very much. A really interesting question. And I think one of the other ways that you can look at this is, instead of doing a risk assessment, what does a safety plan look like? What does a safety assessment look like? How do you keep people safe, you know, in that orbit? And also, just coming back on the sort of different tolerances, I think this is a really interesting point, because you know, one policy is saying what we do and don't tolerate, and what that comes out in as behaviours in another arena looks very different. And libraries is one of those tension points where actually some of the training we're doing is training that we used to do in A&E. And we're now sort of cascading that down into places like libraries because of the escalations. Mark, welcome from Newcastle.
Hi, Louise, thanks. It was just a bit of a follow-on from Frankie's question, and I do think it's a really pertinent one, because trying to develop policies and procedures that give a finite solution or a finite direction to staff is really difficult. And when you're dealing with a really diverse range of presentations, it's hard to capture a response that will cover everything and all eventualities. And I just wonder, from Frankie's perspective, have you considered developing a set of guiding principles? So rather than saying this is the policy and that policy is almost set in stone and people look to follow that policy, which is quite often how things play out, is there a means by which you could create a set of guiding principles with potentially some rules attached? So some absolute finite statements, typically they would be around things like harm and risk, but then a set of guiding principles that actually give staff the space to manage a set of circumstances, because, as I've said, those circumstances will vary quite widely. So it's more about providing staff with the environment and permissions to behave in a certain way and manage a situation, than giving staff direction through a policy. I don't know if that's helpful or not, but
Yeah, no, it is because I've like sort of what I've written up at the moment is more of like a flow. It's like it's a policy, but it's more of a flow chart, if that makes sense. Of like, and it's that what happens after the incident, that initial review, like what does the service user feel like they weren't getting their needs met, that we like what do they feel like meant the situation happened, and then for the staff member, do they feel safe to carry on working with that service user? Are there any like boundaries we need to put in place, like maybe phone to phone contact for a little bit, that sort of a thing. So I think I think it's just more like it's quite it almost looks like a grievance process at the moment, and I'm like, is that the right way for it to be? It's obviously not got the same sort of outcomes and stuff like that, but I just don't know if I'm handling it in the right way. Basically, it feels like a review, which feels safe for me because it means it's individual, but the process is always the same. But then I don't know if someone would read that and be like, oh, now I have to go through all these things before I get an answer. But I do feel that's necessary.
yeah, I think another thing to consider is how you can get your staff to write the policy and set the guiding principles. And again, this talks to a point that Abs made earlier on, and it's something I've seen in our work in Northumbria quite a lot, is that the people who are making decisions, who are defining strategy, policy, are often so far removed from the actual thing that what they develop often isn't practical at the point of delivery. And I'm really sorry for a delivery coming by the sounds of it. I just need to get the door.
Okay, yeah, thanks so much, Mark. I'll put in the chat box about the liberating method that was borne out through a lot of work that people did up in Northumberland, and it was around actually the kind of rules, do no harm was one of them. I'm not going to remember the rest of them, but actually using principles and having local leaders, because what you need to have is that dynamic response that you can do where you feel that you are trusted and held by your team, by your organisation, around positive risk taking and dynamic sort of risk assessment, safety assessments, and so on, because there will be lots of moments where this isn't quite right. But as Mark said, because the policy making is often built in through a kind of a culture of corporate sort of responses and medical models and all the rest of that, is that it does look exactly like you've well described, that it ends up looking like some sort of performance review rather than anything actually useful. So really, really good points. Abs, back to you.
Thanks. Hi, Frankie. I know we're kind of talking a lot about this, but again, it's quite relevant. So again, what I've done in the past, which has worked, is done a consultation. So again, if we're reviewing this sort of policy, ask the staff what's their issue. So again, it's a bit like you've captured that you said, and then what you do is capture that and then write your draft and then run a tabletop exercise. So again, go through these scenarios as to what you've done and what you're proposing to do, and run it through like a real scenario with your members of staff or selected members of staff, and then see how it works in practice. Because then if they say, actually, this is really good because we've not considered this before, the guiding principles are good because it gives that free flow of your decision making isn't so rigid. So what you perceive as a threat, others might not perceive as a threat. So again, but it doesn't make it wrong, but equally it's how you manage that. But that way, what I found is when I've done a consultation with staff members, written a policy, done a tabletop exercise, you get more buy-in because people feel like they've been listened to. You've tried to address the problem, or you've addressed the problem, and this is a sort of solution moving forward. And by running it, what you're doing is see if there's any failures of the procedure that you're going to write. There obviously still could be, but I think that's the best. And then you can feedback. So actually, you said this is the policy, this is what we did, sort of thing. So
yeah, that was fully my intention, to have a review process with the staff. But we didn't have any policy whatsoever, so I kind of got to go with them with something first, if that makes sense.
Well done, that's good.
That's
And
brilliant.
it comes from, like, with my old workplace, we had such negative experiences around challenging behaviour where we just wanted, as a staff force, to support people, but actually what it meant was, when in trying to be trauma informed, we had no boundaries, which isn't trauma informed work. So it's like something that I'm really trying to carry into my new role, basically, because I was on the junior staff member receiving end of poor policy management, basically.
Yeah, and brilliant for you for doing that. And I think sometimes that kind of if there's nothing there, start building something. I guess, and try and articulate that. We do have lots of values within organisations that are saying we're going to collaborate with people, we're going to be future focused and all the rest of those sort of values. And actually, the values driven is actually we need to be working with our staff that are actually on the front line and looking at this type of thing every day and asking the question, how do we support them, not the other way around? Because it feels like sometimes we're sort of looking down the wrong end of the telescope. Thank you so much for that. It was really, really insightful. Anybody else got any questions or comments they would like to give? Daisy.
Hello, thanks for having me. I'm an infectious diseases doctor at the Royal Sussex County, where we have a lot of multiple disadvantaged patients. I think I popped in the chat, but it would just be really good to know. Really enjoyed the talk from the Joes about sort of the restorative approach, but I think in the acute setting, we often struggle with that a lot, and we end up being quite reactive and defensive. And then you've got often a quite acute situation, similar to other people's situations, where you haven't got that time to sort of pause and go away and de-escalate things. So there's still an immediate need for medical care. So if there's sort of strategies people have found effective in terms of de-escalating or sort of shifting from that reactive approach to a more restorative approach when there is sort of a need for ongoing interaction, and sort of you can't have a step away and take a moment. Thanks.
Yeah, and I think one of the big tensions in A&E and spaces like that is exactly, you have to do something now, regardless of what's going on around you, and so you're kind of held in a sort of evolving dynamic. And I think going back to Mark's point around principle-led operation, it's like think about your first sort of prerogative is not doing any harm, but actually some of those principles, something may happen. And this is where Suzette Woodward's, the safety 1, safety 2 thing comes in around learning from excellence, or, it's actually what do you do well? Can you keep doing something that's operating well? How can you learn? How can you use things that go wrong as a learning experience rather than a blame shame exercise? Just going back to the kind of aviation example. And a constant communication about what worked, what didn't work. In university hospitals, you have a huddle board up on the corridor somewhere, where you could put change ideas, and it's very much about negotiating with people around. We've noticed this. I think also in A&E, there has to be some sort of response that's multidisciplinary around the connection between social care, what they can do and help with in terms of if there's an evolving situation, if people are known. Then what is that communication between the police, A&E, and other areas of work where we can have more of a rapid sort of response or learning from each other, which is what this space is about, and doing more of this type of relational learning might be useful. Joe.
Yeah, I think obviously we we work in quite a different setting in terms of not necessarily acute immediate need. I would say there's still some things from the sort of restorative approach I think can be applicable, like in those more sort of I guess one-off interactions where you're seeing someone for a specific purpose. I think it's still important to try find small ways to help that person to feel at ease. Those small, I don't know, even using humor to build that element of rapport through an appointment can be really valuable. If things are challenging, say generally trying to avoid you statements in terms of saying you shouldn't do this, you're not allowed to do this. It's difficult for us to support you with XYZ if this is happening. And yeah, one of those sort of trauma-informed principles would be rejecting the behaviour of the person, and so the use in that frame, I think, is important. And then the final thing, I guess, is perhaps like Louise's slide on the sort of build up to an incident occurring. And that's maybe more of a system thing around people getting to the stage where then their needs are so unmet and the need becomes so acute that when they come into settings like more acute hospital settings, the frustration, the build up of feeling sort of let down and excluded from services for so long can then, can result in these larger incidents occurring. So that's probably more of a sort of system question in terms of the impact of that.
Yeah, thank you. And yeah, I think it's about if we can do things further downstream, and have sort of, better ways of the welcome in terms of that design. What does the kind of welcome look like? What does the waiting look like? Because any opportunity we have to de-escalate, some of the situations when we see them kind of moving into us, it can help, and we won't be able to avoid all of the problems that come in, but we can minimize, and reduce the amount that we do have, and again using them as learning experiences to think what would we do differently next, rather than sort of blame and shame. We'll get a better result in the end, over time. Back to Joe.
Yeah, but I guess from just like a really practical standpoint, like often people that may be coming into these settings with perhaps presenting with challenging behavior, they're going to be community practitioners that know that person really well and maybe have worked with them for a long time. But like practically, none of our systems align. So the knowledge and sort of understanding we have of that person and how best to work with them might be recorded on one system that a homelessness team uses, but it's not accessible to another team that's working in a health setting. So I think there's a question mark over how knowledge is shared around how to best meet the needs of each individual across the system, and even like really sort of bullet pointed things that might be triggers, things that are good ways to sort of make people feel at ease. I think could make a big difference if that was more easily shared.
Yeah, and certainly something across the system we're trying to work on desperately is that information sharing. It's a massive barrier. Frankie.
Sorry, if anyone else has questions, I'm happy to go at the end. But I think something else that comes up for me is like the third sector. We talk a lot about the third sector, like being that little fishing net underneath the statutory services sometimes, and like filling up those little gaps that statutory services don't always can't hit because of their thresholds, or they've like there's boundaries in place, or but oftentimes, and you would come across a person that has been removed from or has so much difficulty with certain statutory services which technically would meet their needs more than you can, and you have this sort of guilt of like putting in those boundaries in your own service because you do just think they're just going to be out there wandering with no support around them whatsoever, because like some people they're showing these really difficult presentations, and technically that it's not safe for you guys to be working with them because you don't have the training and you don't know how to respond effectively, especially when it comes to like aggression and violence and stuff like that. But you also have that guilt of, if we remove them from our service, they've experienced so much hardship in all these other services, like where are they going to go? And I think that can be such a difficult feeling. I don't really have a question in it, but it could be such a difficult feeling for a staff member, for a support worker, and like in all levels of an organisation, because obviously we're all doing it because we want to support and help people. And when you just feel like you're just not abandoning someone, it is setting a boundary. But I think that feeling can be so difficult to, when you know someone well enough to know that the other services aren't going to let them in either. I think that becomes really difficult for people.
Yeah, and thank you so much, and that's probably going to be a sort of bit of a closing comment there. Thank you very much, Frankie, for that. This is a continuing conversation. I hope that we can have more of these. A big round of applause really for Joe, the two Joes, and for Abs for their talk today, for the contributors and for listening. Thank you so much. Final word for Joe before we close.
Yeah, just aware there were a couple of comments in the chat we didn't get time to respond to. I'll put mine and Joe's emails in the chat, so if anyone wants to follow up with us afterwards, we'd be more than happy to do that.
Great, thank you, and we will be sharing notes and the presentation as well, with a thank you for being here. Email, that's what it is. Thank you so much. Enjoy the rest of the day. Don't get too wet. Goodbye.
Thank you.
Thanks, everyone. Thanks, Louise.
Bye, everyone.
Thank you.
I think there's a separate link for the other one.
Yeah, so I just we can stay here.
I'm going to have to shoot off imminently to actually go and see some challenging clients. But
Oh, come on.
my feeling was that went very well. So thank
No, no,
you
I'll just
for having us, inviting us, Louise.
do that bit. No, thanks very much for hang on, just stopping the